So if we look at, or if we draw a picture. So let's say here's your heart, and your heart's kind of rotated because it's kind of turned to the side. But over here on the right hand side, we'll see our superior vena cava coming up. We'll say that's your superior vena cava. It's going to bifurcate. One's going to go all the way across the body, and one's going to be short. So this would be your left brachiocephalic vein. Brachio or IO? IO. And this one here would be your right brachiocephalic vein. Right. Okay. Then the brachiocephalic veins bifurcate. One goes up the neck and one goes over the shoulder. So this one here would be your left subclavian vein. And this one here would be your left internal jugular vein, right? You guys already know that one? Over here we have one that goes straight up the neck. That'd be your right internal jugular vein. And then we have one that goes over the shoulder. That'll be the right subclavian vein. So pretty easy division. That left brachiocephalic vein definitely crosses over. Now we can put in the large bore IVs that I previously talked about. Remember I talked about subclavian, not subclavian, central venous lines or central venous catheters. We could put in the catheter into an internal jugular vein, but when you do a chest x-ray, you will actually see that catheter come in here, it crosses the body, and then it goes into the superior vena cava. Or you can see it insert a subclavian vein, which sometimes you can see it insert here, and then it still tracks down the brachiocephalic veins. And so that's the path it's taking, but you're seeing it on the chest x-ray. So for instance, did Professor Sheng talk about subclavian vein, or not subclavian, I just wanted to say that. Central venous lines, seeing them on chest x-rays? When you guys did chest x-ray interpretation?
A little bit maybe.
Hopefully. Chest x-ray, central venous line. Images. So let's see here. That's a good one. Central venous catheter. I want this one. I want to see one crossing the body. Where the heck?
Did you say that they could be inserted in just the internal jugular or both?
Usually you choose one or the other.
Okay.
So like these here, this one here is actually, you can see it inserted. This is probably internal jugular. I'm thinking this is the central venous line. So since it's coming straight down the neck and then it's disappearing here in the superior vena cava, that'd be internal jugular. I wanted to see one cross in the body so you can see in the brachiocephalic vein. I'll try to find one. Oh, here's one. Yeah. So this is one. I'm gonna move it down so I can point it down. Okay. So anywho, there's this one here. So they inserted this line here, subclavian vein. That's why it's around the clavicle. But we can see it crossing the body. So it's crossing in the left brachiocephalic vein, and then it's going all the way over here to that right side of the heart, and it's disappearing in the superior vena cava. These catheters, we don't want to insert them into the right atrium. We want to just have them stopping at the superior vena cava because it's mixing with all that venous blood that's coming back from both brachiocephalic veins and the superior vena cava. What about here? What's that shame? But anyway, I just wanted to show you guys because you'll see the different anatomy. This is kind of a full picture here. Somebody's overlaid their basically exactly my picture. Superior vena cava, your brachiocephalic veins, then you have your two internal jugular veins, and then your two subclavian veins. But those are just different routes for it. But that's how it'll look on your chest x-ray. Does that make sense?
Yes.
All right. So also coming off the heart is your aorta, right? I'm actually going to show you in the lab. I've dissected out a lot of this. This is all thymus gland, but I removed it all for you guys. You're actually going to be able to see the pulmonary trunk coming off the heart, and you're also going to be able to see a little bit of the aortic arch. That aortic arch is going to be back here. It's behind these structures, but that aortic arch is going to be behind that left brachiocephalic vein. Now I've separated it all out so you can see it better, but you need to know the three divisions coming off of your aortic arch. There's always three major blood vessels at the top of the aortic arch. So if I'm looking at the aortic arch, we can draw it. So let's say here is your aorta coming off the heart. We're going to have the arch here, and then it's going to get down, right? But there are three branches coming off of it. Your first branch is over here. So the first branch coming off the aortic arch, we're going to call it the brachiocephalic trunk. Think of it as a tree trunk. So I'm going to draw it out here. So brachiocephalic trunk. It will then bifurcate. And we can see it here. We can see this brachiocephalic trunk coming off, and then it bifurcates to two vessels. The one vessel is going to go straight up the neck. I bet you guys know what that vessel is. What's a large blood vessel going straight up the neck? The common carotid artery. So that's where the common carotid artery originates from. Common carotid artery. And that's on the right side. Now, it will also have a branch that then goes underneath the clavicle. And that's your subclavian artery. So right subclavian. So you have a right subclavian artery and you have a right subclavian vein. They both go underneath the clavicle. I'm going to draw this picture and Tom will be correct. Should be a bigger arch. Let's do it like that. Your next branch off your aorta is going to go straight up the neck on the left side. What do you think that is? The left common carotid artery. And then the third branch it's gonna go underneath the clavicle. And that would be my left subclavian artery. So first branch is brachiocephalic vein, no, brachiocephalic trunk. The next one is your left common carotid artery, and then the left subclavian artery. But that brachiocephalic trunk bifurcates to the common carotid artery on the right side and the right subclavian artery. Why do you think it needs that brachiocephalic trunk? And not just branch off the aorta? Because that aorta is more on the left-hand side. It's gotta cross over the mediastinum and then it bifurcates. Just how like that left brachiocephalic vein was longer because it had to cross the body. Well, same thing with the brachiocephalic trunk. It needs to cross the body before it bifurcates. Does that make sense?
Yes.
I wanted to dissect out something for you guys because it's so beautiful, but I didn't. I wasn't able to say that. But off your subclavian artery, you have all these branches of, it's called the thyrocervical trunk. That could be a bonus question just because I love it. It's a whole bunch of different arteries. It just looks like a little spider thing that coming off the common carotid or the subclavian artery. It's so cool. Like, I had to learn the thyrocervical trunk, so I had to learn all these different blood vessels coming off of it, but
What did you say it was called?
the thyrocervical trunk. It should be 32 on there.
32 on the book.
Yeah. But I loved all the little vessels. It just looks cool and how complex it is, but I did not save it. I actually cut one of the vessels off. I'm like, oh, I didn't save it. But our dude, our body that I've been dissecting, he has such a large heart, and everything is just so constricted in him. His heart. I actually broke one of his clavicles to try to just open up and break and give him some more room to look at some of these structures. Yes.
What did you say that came off of?
The subclavian arteries.
Subclavian
Both
artery?
sides, you'll have a thyrocervical trunk off of both sides.
Both sides.
You'll see it better on the right-hand side. But it is what it is. Okay, so we know the carotid sheaths contain your intrajugular vein, your common carotid artery. That's why those structures are running together. What's that other nerve that runs in the carotid sheath?
The vagus nerve.
Your vagus nerve. Now the vagus nerve runs down both sides of the neck, but it does something funny. It does go all the way down to the heart. So you'll see the vagus nerve come down the right side. I'm going to draw in green. It comes down the right side and it goes all the way down to the heart. And then on the left side, it comes down this side and it goes to the heart as well. But it has a branch off of it. And I dissected out both sides of this nerve. On the right side, it has a branch off and it loops under the right subclavian artery. So on the right side, it has a branch that comes off of it and it loops. Literally, it goes underneath the subclavian artery and then goes back up to the neck. It goes back up to the larynx. But on the left side, it does something funny. It doesn't go over the subclavian artery. That branch comes off and it loops underneath the aortic arch and then goes back up to the larynx. So it literally, you'll see a branch come off of it and it goes underneath the structures. Those are called the recurrent laryngeal nerves. And they innervate the larynx and they actually participate a little bit in our vocal phonation. So they actually go into the vocal cords. So they're called the recurrent laryngeal nerves. So this one here would be the right recurrent laryngeal nerve. this side, it loops under the aortic arch. I'm gonna draw an arrow. But that would be the left recurrent laryngeal nerve. Why are they important for us? Well, people who get lung cancer will develop tumors in their lungs, and if a lung tumor puts pressure on one of these recurrent laryngeal nerves, your patient will sound very hoarse. They'll sound like their throat's sore and they can't talk. We don't have nerve endings in our lungs, so we don't have pain associated with lung tumors forming. And so sometimes one of the first signs of lung cancer may be a hoarse voice for no reason. And typically, it's a left-sided lung cancer that's putting pressure on the left recurrent laryngeal nerve. The right recurrent laryngeal nerve is really not as affected by lung cancer because it's so much higher. It loops underneath that right subclavian artery, right? But the left one, it's way down here. That nerve comes all the way down here and it loops underneath the aortic arch, right around here. And so here's your lung tissue, and that's why it puts pressure on it. Dr. Petroff will loves to talk about this when he has you guys for like the pathology courses or his seminar course. He'll talk about that left recurrent laryngeal nerve. So this is, I know it's before your guys' time. So there used to be a news anchor. His name was Peter Jennings. Does that ring a bell to anybody? I think he was on CNN way back in the day. He was on the TV. I grew up with him. He covered the Iraqi storm wars that my wife's father was in. He covered September 11th when the towers fell. But he was a known smoker. He smoked pretty much all of his life. At one point when he was doing the newscast, he started having this hoarse voice. And so I want to show you a video of him. He's since passed away. But I'm going to show you a video of him. It's his last sign. You can hear his voice, and that's because he had a tumor that was putting pressure on his left recurrent laryngeal nerve. So Peter Jennings. Last. No, I'm gonna go to YouTube. Peter Jennings' last show. This is the last show.
Scientists even know about change. Some of you have noticed in the last several days that I was not covering the post. My colleagues at ABC did a superb job. I did think a few times I was missing out. However, as some of you now know, I have learned in the last couple of days that I have lung cancer. Yes, I was a smoker until about 20 years ago. And I was weak, and I smoked over 9/11. But whatever the reason, the news does slow you down a bit. I've been reminding my colleagues today who have all been incredibly supportive that almost 10 million Americans are already living with cancer, and I have a lot to learn from them. And living is the key word. The National Cancer Institute says that we are survivors from the moment of diagnosis. I will continue with the broadcast. On good days, my voice will not always be like this. Certainly, it's been a long time, and I hope it goes without saying that a journalist who doesn't value deeply the audience's loyalty should be in another line of work. To be perfectly honest, I'm a little surprised at the kindness today from so many people. That's not intended as false modesty, but even I was taken aback by how far and how fast news travels. Finally, I wonder if other men and women ask their doctors right away, "Okay, doc, when does the hair go?" At any rate, that's it for now on Folk News Tonight. Have a good evening. I'm Peter Jennings. Thanks and good night.
So you guys able to hear his voice a little bit? it didn't sound like the normal Peter Jennings if you grew up with Peter Jennings, but it definitely was hoarse. It sounded like a hoarse voice. And so that's because that left or front laryngeal nerve involvement. Cool? What other structures when you cover the mediastinum? I think that's it. I do have a picture up here of the mediastinum for you guys. That shows those 3 branches off the aortic arch. It also shows, phrenic nerve. When we were learning the phrenic nerve, you guys learned that the phrenic nerve was laying on top of the skull, right? I have now dissected out those both phrenic nerves all the way down to the diaphragm. Take that back. I did the right one all the way down to the diaphragm. The left one, because that heart, his heart is huge. It's so tight in there. I went all the way down to where I couldn't get around the heart anymore. Now, if you guys want to, though, after your guys' final exam with me and we're done with the bodies, if you guys want to come into the lab and remove the heart and lungs, we can totally do that. That'd be on after everybody's final exams up. But we could definitely see a lot more when we do that kind of stuff. If y'all are interested, that's not a mandatory class activity, but if you are interested and you want to learn a little bit more. But you will see the phrenic nerve. So we have the vagus nerve here, but you will also see the phrenic nerve. And the phrenic nerve actually goes on top of the pericardium. It's interesting. When you get down to the heart, that pericardium almost looks like it has 2 layers. One of the layers is the parietal pleura, and the other layer is the pericardium. That phrenic nerve goes in between the parietal pleura and the pericardium. You actually have to remove the parietal pleura to access that vagus nerve on the side of the heart. But it goes down both sides of the heart, all the way down to the diaphragm. So if we look at the mediastinal structures, you need to know the brachiocephalic trunk. Inferior thyroid veins, don't worry about. Those are not dissected out. Those are veins that come on from the bottom of the thyroid glands, but don't worry about it. You need to know the internal jugular vein, which you guys already know. Internal thoracic arteries and internal thoracic veins, you guys know them. They come off of both thyrocervical trunks, but you know them because they're on the inside of the chest plate. Remember those veins and arteries that go both down the side of the sternum? They come up here off of the subclavian artery, but we have to cut them to remove the chest plate. So I will test you them on the chest plate, not necessarily in the mediastinum. Does that sound good? But they do come off the thyrocervical trunk. Of course, you know the thyroid gland, so the isthmus of the thyroid gland and the lateral lobes of the thyroid gland. Now that I've dissected out the sternum or the mediastinum, y'all will see that thyroid gland even better. You need to know left brachiocephalic vein, left common carotid artery, the left vagus nerve, parietal pleura, yes. The phrenic nerve, yes. The right brachiocephalic vein, yes. The right common carotid artery. You do need to know the right recurrent laryngeal nerve as well as the left recurrent laryngeal nerve. I don't have a left recurrent laryngeal nerve on there, but please make sure you add it. There's a recurrent laryngeal nerve both right and left. Of course, you know the subclavian arteries right and left, vagus nerves right and left. I think you should know the scalenus anterior at this point, the subclavian vein, superior vena cava, the trachea. Don't worry about the upper roots of the brachial plexus. I'm not having you guys learn the brachial plexus. We're not crazy, right? Not a crazy amount of new structures. A lot of them are repeats that you've already learned, but now we're going to get a better view of them. Heard? And then let's go over posterior abdominal wall. I'm going to take off posterior thoracic structures. We are not removing the lungs, so don't worry about that. Those are veins on the backside of the thorax. Actually, those drain blood the azygous vein, the sextrazygous vein, the hemiazygous vein, those all drain blood actually from the lung tissue, but don't worry about it. Posterior abdominal structures though. That is going to be on page 261 of the old book, 270 of the new book. What's the best way to do this? Ugh. Okay. We're looking at this page right here. So this is, all of the stomach contents have been removed. So in the PT bodies, they've done what they call an evisceration. They've done the abdominal evisceration. And so we're able to see these structures on the back side of the abdomen. Coming down from, so above kind of where that picture is kind of cut off, that's kind of like the area of the diaphragm. So these are below the diaphragm. Coming down from the diaphragm, you're going to have a big artery. So that's your abdominal aorta. So we learned the thoracic aorta, right? Where it crosses through the diaphragm, past the diaphragm, we call it the abdominal aorta. If you have somebody that has a AAA or an abdominal aorta aneurysm, the aneurysm is off this abdominal aorta. But the aorta comes down, and then it's going to bifurcate. It's going to split into two vessels. And those are called the common iliac arteries. So it bifurcates the common iliac arteries. Then it's going to bifurcate again. We can see that division right here. One is going to go kind of further out of the abdomen, and then one goes way deep into the abdomen. It follows that abdominal wall and it goes way deep. So if one goes deep, it is the internal iliac artery. And then the one that's on the outside is going to be the external iliac artery. So we have a, for instance, on this side, we have a left common iliac artery, and it bifurcates to the left internal iliac artery and the left external iliac artery. Cool? That external iliac artery is going to cross this band here. It's a ligament, and it's called the inguinal ligament. The inguinal ligaments on both sides, if you have a really big like muscle build or bodybuilder, they have that kind of V shape at the bottom. That V shape is caused by the inguinal ligament. But once that external iliac artery crosses the inguinal ligament, then it becomes the femoral artery. And that is the site that we stick for APGs. Sure. So once the external iliac artery crosses the inguinal ligament, then it becomes the femoral artery. And so it'll do that on the right side. So you'll have a, let's say, a left external iliac artery, you'll have a right external iliac artery. Once those external iliac arteries crosses the inguinal ligament, then you have a left femoral artery and a right femoral artery. Same thing with the venous side. Okay, we're not very creative with their names. So 23 coming down the body, that's your inferior vena cava. So the inferior vena cava comes down, and it's harder to see in this picture because it's kind of hidden by this right common iliac artery, but it does bifurcate, and we have a left and a right common iliac veins. The common iliac veins then bifurcate. One goes external, one goes deep. So it's going to be the external iliac veins and the internal iliac veins. Same thing with your external iliac veins. Once they cross the inguinal ligament, they become the femoral vein. So we will have a femoral vein, we'll have a femoral artery, but right next to the femoral artery, you're gonna have this huge nerve, and that's the femoral nerve. And guys, just like those intercostal vein, artery, and nerves that we talked about last week when we talked about chest plate and how it's spelled van, these spell out van too. Start midline, you'll have vein, artery, nerve. So always start midline, vein, artery, nerve. Same thing on this side over here. If we start midline, the vein will be closest to the midline, then we'll have the artery, then we'll have the nerve. There are two other structures that you need to know. I cut off a lot of the renal stuff. You'll see renal arteries and renal veins come off of the abdominal aorta and the inferior vena cava. But I do want to, you also have gonadal arteries coming off of them. You're going to see all these branches, like right here, there's going to be a branch coming off of this. And some other ones too, you'll see branches coming off of it. The gonadal arteries, you don't need to know them. They go down to your gonads. They're what supplies your gonads with, or your reproductive organs with blood. But there are two vessels I really want you to know. There's going to be one vessel, we'll have to go through the PT bodies and see if you can see it. One blood vessel is going to come off the aorta, and that's your inferior mesenteric artery. Do you guys know what your mesentery is? It's all the blood vessels in between your intestines. You'll have an inferior mesenteric artery, and then you also have a superior mesenteric artery. That one's higher. Sometimes PT rips them off because they don't pay attention to them, and you'll just see a hole in the aorta, and that's where they ripped off that artery, or either of those arteries. So you have an inferior mesenteric artery and a superior mesenteric artery. The inferior mesenteric artery is going to be closer down here to the bifurcation of the common iliac arteries. Superior mesenteric artery is actually going to be higher. It's almost way up here by the diaphragm. And I'll show you what the mesentery looks like on our patient. We'll cut open the abdomen today. There is another structure which is called the celiac trunk that I want you to know. And it's going to be way up here by the liver and the spleen. Can I erase the heart picture? Does anybody want to take a picture? Let me turn on the light so you guys take pictures. Just don't judge my artistry. That's cool. These whiteboard paints are great. It's like just don't erase for long. Okay. So on these arteries, on your, let's say this is the abdominal aorta come down, and then it's going to bifurcate to the common iliac arteries. Abdominal aorta. Here, you'll have a branch coming off. That's your inferior mesenteric artery. We'll have another branch coming off. That's your superior mesenteric artery. But then up here, you'll have this vessel that looks like a T. inferior mesenteric artery. The trunk of that is called the celiac trunk. And I think it's C-O-E-L-I-A-C. Celiac or coeliac trunk. That supplies blood flow to our spleen and our liver. Over on the right-hand side, we're going to have a blood vessel coming this way, and that's called the common hepatic artery. Common hepatic artery. It goes to your liver. Over here, this blood vessel is really, really long, and that's called the splenic artery. Splenic artery. It goes to your spleen. So this would be your superior mesenteric artery. And your inferior mesenteric artery. These are common vessels that get torn and damaged whenever you have somebody like in a car accident. Sometimes you'll hear they'll have a mesenteric injury, or they'll have damage to the splenic artery or common hepatic artery. But like I said, when PT does this, you might just see a hole and a hole because they've ripped out these arteries. Sometimes they don't dissect out the celiac trunk. A lot of times we'll find one, but we gotta look. Cool. And I think that's it for posterior abdominal wall. Let's go look at this. So posterior abdominal wall, of course you know the abdominal aorta. Bladder, don't worry about the bladder. But you need to know common iliac vein, common iliac arteries, both right and left. External iliac arteries, external iliac veins, right and left. Femoral arteries, femoral nerves, femoral veins. Inferior mesenteric artery, inferior vena cava, inguinal ligament. Internal iliac arteries and veins. Y'all should know the rectus abdominis muscle, right? I think it's just on our list because it's in the picture of your book. Superior mesenteric artery, yes. Sympathetic trunk and sympathetic ganglia. You don't need to know. Those are nerves on the posterior abdominal wall, but I won't go over them. And then ureters, well, if PTs remove the kidneys, they remove the ureters. That's where you have urine flow from your kidney to your bladder. Very easy to confuse the ureter with the gonadal arteries, but you don't need to know that. I think they're going to be all removed. Does that sound good? And there is class. Ministry's done. Questions? Okay, let's go back.